So in this PowerPoint, we'll discuss diabetes and the complications that can occur with them. So when we're thinking about complications for diabetes, acute complications are going to be things related to hypo and hyperglycemia. So specifically with hyperglycemia, there's the risk for diabetic ketoacidosis, also known as DKA, or hyperosmolar hyperglycemic syndrome, HHS, or that's also known as hyperosmolar hyperglycemic non-ketotic syndrome, meaning HHNS. Those two are synonymous. And then, of course, hypoglycemia. Now, chronic conditions are related to those micro and macrovascular changes. So that's with the heart, the eyes, the kidneys, the nerves, complications of the feet and lower extremities, skin issues, infection, and of course the psychological considerations. So when somebody has the hyperglycemia, it can be because there's not enough insulin working, or hypoglycemia, there's too much insulin working. And we talked about those acute complications of the DKA, HHS, and hypoglycemia. When a patient ends up with DKA, it's a profound deficiency in insulin, and so this is going to be noted with hyperglycemia, ketosis, and so those ketones are going to be in the urine and in the blood. Acidosis from those ketones, as remember from our acid-base balance, we know that ketones are acidotic. And then most disturbingly is the patient will have profound dehydration. DKA is most likely to occur in patients with type 1, but it can happen with type 2 when somebody has severe illness or stress and the pancreas cannot meet the demand for the insulin needs. So again, those risk factors for DKA, illness, infection, we know that with those, they're going to have increased cortisol production, so there's going to be more glucose, so not enough insulin to treat that. They may not have taken an adequate insulin dosage, undiagnosed type 1 diabetes, poor self-management, or neglect. So again, when there's not enough insulin, the glucose cannot be properly used for energy. So the body breaks down fats, which produces those ketones, which, as we've talked about many times, that is an acid byproduct, which causes there to be serious problems. It causes that metabolic acidosis. We'll see that ketones in the urine and our electrolytes are going to get out of whack. The insulin deficiency impairs the protein synthesis and causes excess protein degradation, meaning breaking down. Degradation is like breaking down of things, which leads to nitrogen losses from tissue. Insulin deficiency also stimulates the production of glucose from amino acids from proteins in the liver and leads to further hyperglycemia. Additional glucose cannot be used and the blood glucose levels rise further, adding to the osmotic diuresis, therefore that extra dehydration that we're talking about. So if the hyperglycemia is not treated, we'll have that severe depletion of sodium, potassium, chloride, magnesium, and phosphate, secondary to that osmotic diuresis. The patient may end up with vomiting, which of course leads to more fluid and electrolyte losses. The severe hypovolemia can lead to shock. Renal failure may occur because of the ketones and glucose, and acidosis progresses. If it's untreated, the patient will become comatose as a result of the dehydration and electrolyte imbalances and acidosis, and the patient may die. So what are the signs and symptoms we're going to see with somebody with DKA? Again, that dehydration is one of the big things we're worried about. So we're going to see poor skin turgor, dry mucous membranes, increased heart rate because the heart's trying to compensate, orthostatic hypotension. Early signs are going to be that lethargy and weakness, and as they become severely dehydrated, the skin is going to be dry, loose, eyes become sunken. They may have abdominal pain accompanied by that decreased feeling of being able to eat, decreased appetite, nausea, and vomiting. And remember the saying, sugar's hot and dry, sugar's high. Another thing we're going to note is those Kussmaul's respirations. Again, the respiratory system is trying to make up for this metabolic acidosis. So the patient is going to have rapid, deep breathing with shortness of breath. And if you get close up, you'll actually notice that sweet, fruity odor, that acetone from the ketoacidosis. Now, surprisingly, you would think a patient with DKA would have to have a really high blood glucose, but really it only takes a blood glucose greater than 250. Of course, our pH less than 7.3. Now, we know that 7.35 is our low normal. A bicarb level less than 16. Moderate to large ketones in the urine and serum or serum. And the initial serum potassium may be normal or high, secondary to that acidosis, but the potassium must be monitored due to the large diuresis. And once we give insulin administration and treatment, it can lead to significant hypokalemia. So they're going to start out high and have a risk for going low, which will make sense into some of the things we'll talk about shortly. So, of course, as always, maintaining a patent airway is going to be important. Remember, this person can become unconscious, and so that's why that airway is going to be concerning. Oxygen administration, we're going to want to get a large IV in them, and they're going to need fluid resuscitation. And you can sometimes give somebody a liter of normal saline per hour. And we want to do that until the blood pressure is stabilized and the urine output is at 30 to 60 milliliters an hour. Now, they may also use half normal saline initially. It kind of just depends. And then they will give IV insulin. They may start that as a bolus and or a drip. And that's going to help with that hyperglycemia and hyperketonuria. We don't want to drop the serum glucose too rapidly because that can cause that cerebral edema. So the insulin is going to allow water and potassium to enter into the cell along with glucose, and then that can lead to depletion of vascular volume and hypokalemia. So when you're thinking about like the first thing you're going to do for somebody with DKA, most people are going to think I need to give that insulin. But because of the hypovolemia, you're really going to start that fluid first, right? They can die very quickly from going into shock from the hypovolemia. So in the real world, I'm going to be taking my fluids in there with the insulin at the same time and getting them going. But you know, if you're having to pick one thing to do first, fluids is your most important thing at first. So other things we're going to do is monitor frequent assessments of vitals and O2 saturations, level of consciousness, our cardiac rhythm because of that potassium starting at high, dropping, urine output. We really, and notice that this is in bold, we really want to monitor the breath sounds because as we're fixing that hypovolemia, we know that they could go into fluid overload. So we're really listening for those crackles, especially in our patients, our older patients who have renal or cardiac issues or other chronic problems. We'll be monitoring serum glucose very frequently, and most recently I've seen them using those continuous glucose monitoring on DKA patients, which just makes it so much easier for the patient and the nurses. We're going to watch that potassium. Again, I talked about it being high initially, but we expect it to drop. We're going to be giving some potassium to correct the hypokalemia. So lots of times I'll actually see them add some potassium after that initial fluid boluses. We're going to monitor other electrolytes. They might even give sodium bicarb if there's severe acidosis. And later on, they'll add dextrose to the IV fluids for blood glucose less than 250. And again, we talked about that initially. We don't want the blood sugar to drop too quickly because we can see that cerebral edema because of that osmotic diuresis that's happening. Now, HHS, hyperosmolar hyperglycemic syndrome, is also life-threatening, just like DKA. This often occurs in patients who have diabetes, who actually have insulin, but not enough to prevent the severe hyperglycemia. So they still have that osmotic diuresis, and they'll have extracellular fluid depletion and dehydration. HHS is less common than DKA, and you're most likely going to see this in your type 2 diabetics, especially your elderly patients. So some of the risk factors for developing HHS: urinary tract infections, pneumonia, sepsis, and acute illness, somebody who is newly diagnosed with type 2 diabetes. And HHS is often related to the impaired thirst sensation or the ability to replace fluids. So getting a good history of their fluid intake, looking for the inadequate fluid intake, or increasing mental depression and polyuria is going to be one of those things that are going to help us to differentiate this. Again, the main difference between HHS and DKA is that HHS usually has enough circulating insulin, so there is not ketoacidosis. So we're not going to see ketones in the urine or serum. HHS produces minimal symptoms in early stages, but the hyperglycemia will be much more pronounced before HH is diagnosed. So we're going to see blood sugars in the 700s. Not that you can't see that with DKA, but typically in HHS, we're going to see a much higher blood glucose level. So some of the complications from HHS are secondary to that increasing osmolality. And if you remember, osmolality is that concentration, which produces more severe neurological manifestations. So somnolence, we've talked about somnolence before. This is when somebody is more than lethargy. So they're really very, very out of it, but not in a coma. Seizures, hemiparesis, aphasia. And if you think about hemiparesis and aphasia, that's going to look a lot like a stroke. So one of the things that we do when we suspect a stroke is we do that blood glucose right away. And we're always actually looking for hypoglycemia with when we're lots of times thinking a stroke. But at this point, the blood glucose is probably going to be 600 or higher, and we would see marked increase in the serum osmolality. Ketones are absent or marginally minimal in the blood and urine. So as mentioned earlier, HHS is a medical emergency. There's a very high mortality rate. So the management's going to be similar to DKA. We're going to give large volumes of fluid. Generally, it's going to be that normal saline or half normal saline. The fluid replacement does have to be done slowly and carefully with HHS because, again, it's much more common in the elderly and especially with those with cardiac or renal issues. And so once they get to a blood glucose level of 250, dextrose is added to the IV fluids to prevent the hypoglycemia also. So electrolytes are going to be monitored and replaced as needed. Hypokalemia is not as significant in HHS as it is in DKA. The fluid losses can precipitate the hypokalemia. We're going to be monitoring vital signs, intake and output, tissue, skin turgor, lab values, meaning the blood glucose and our osmolality, and cardiac monitoring. We're going to want to make sure we're doing frequent assessments of cardiac, renal, and mental status. And once they're stabilized, we'll initiate attempts to detect and correct the underlying cause. And when I've done literature reviews on this and have read different medical journals and nursing journals, one of the things that's interesting with HHS is that frequently once you correct the fluid volume deficits, the blood sugars will normalize, and this person may or may not even need insulin. So it's really going to depend on this specific case. But again, just like DKA, we're going to give those fluids first. So nursing management at DKA and HHS, we're going to be monitoring blood and urine, glucose and ketones for DKA, glucose for both. We're going to initiate, monitor administration of IV fluids, insulin therapy, most likely that's going to be IV, electrolytes to correct imbalances, assess renal status, cardiac status related to hydration and electrolyte levels, especially the potassium level, monitoring level of consciousness and mental status, cardiac monitoring, vital signs, fever, watching for hypovolemic shock tachycardia and Kussmaul's respirations, which the Kussmaul's respirations is, again, most likely in DKA.